All right. Well, hello everyone and welcome to the Department of Medicine Grand Rounds. I'm excited to introduce today's speaker, Dr. Karin Nelson. Dr. Nelson is a professor in the School of Medicine and adjunct professor in the Department of Health Services in the School of Public Health here at the University of Washington. She's also a core investigator at the Seattle Health Services Research and Development Center of Innovation and the director of the Primary Care Analytics Team for the VA Office of Primary Care. She obtained her MD from the University of Minnesota, did her internal medicine residency at Hennepin County Medical Center in Minneapolis, and her master's in health services from UCLA, where she also completed a general medicine fellowship. Dr. Nelson is a general internist and a health services researcher, and she's focused much of her career on research to improve the health and health care for disadvantaged populations, specifically around primary care policy and community-based interventions for chronic disease self-management. She won in 2015 the VA's Health Sciences Research and Development's Best Research Paper of the Year award for her article titled Implementation of the Patient-Centered Medical Home in the VA, published in JAMA Internal Medicine. She actively mentors many junior faculty and is co-director for the fellowship program in the Seattle HSR&D Center of Innovation. She's also a primary care physician at the VA Puget Sound, where she's had the privilege of caring for veterans for almost 20 years. Dr. Nelson, we're so happy to have you today as our Grand Rounds presenter. To the audience, as always, please feel free to leave questions at any time in the chat, and I'll be watching for that. And we'll wrap up at the end with a short question and answer session. So thank you, and please feel free to begin.
Great. So this is the disclosure slide, moving right along. So thanks so much for attending this talk today. I'm just really sorry we had to do this on Zoom. Before I begin, I'm just going to give you a little bit more background. That was a really nice introduction that Johnny made. I really just want to emphasize that throughout my career, my focus has really been on improving health and healthcare for disadvantaged populations and in studying optimal primary care practice models. And like Johnny said, I've been at the UW since 2001. I've been in primary care at the VA. I've had the same patients, some of them for over 18 years. And today I'm going to talk to you about my work in integrating research and clinical care into a learning health system, both in terms of the work that I've done for evaluations at the national level in the VA, but also work that I'm doing locally around improving chronic disease self-management for high-risk veterans and some local innovations projects that we're sponsoring. So again, I have no disclosures, and I just want to say the views presented here do not represent the Veterans Health Administration. So I have several objectives for the talk today. The first is really just to define what we mean by a learning health system as a framework for healthcare delivery and system improvement, but also as a framework for discussing the work that I've done over the years. One of the core features of this model is really the integration of research and evaluation into health systems. And this is the area that I've spent a lot of my career. So within this framework, I'm going to highlight the work from the Primary Care Analytics Team, or PCAT. Everything in the VA has an acronym, and we are called PCAT. This is an embedded research team that I direct for the National Office of Primary Care in the VA. I'm going to talk about some past projects and ongoing projects we have around the medical home model in primary care, and also highlight some of our ongoing projects that focus on other key areas of primary care policy, such as the care of high-risk patients and telemedicine in primary care. Then I'll turn to work that I do at the local level with local clinical leaders in the VA, at the Seattle VA, with the development of a recent innovations lab for QI. And then another research project that we're targeting high-risk veterans in our patient population. And then I'll end my talk with some discussion and thought about areas I see as challenges in this type of work with health system leaders and some strategies that we've used over the years to improve the potential that our work can improve care and impact policy. And so I'm really going to use this learning health system model as a framework to discuss my care as I go, discuss my research as I go forward. All right. So what is a learning health system? The Agency for Healthcare Research and Quality defines it as a health system which systematically integrates internal data and experience with external evidence to put the resulting knowledge into practice. This is a graph from health services research at the VA, in which a learning health system is envisioned as new knowledge is captured from the clinical experience. I'm going to try to do the pointer here. The central feature of this model is that the patient experience and the clinical encounter are in the middle. And by capturing this data about clinical practice, we can gather and create evidence and apply the most promising evidence to improve care. So this model implies the need for skills in implementation science over here and how to get people to change, and data science for how to analyze all this clinical data. So I'm going to use this framework to put some of my work into the context of the learning health system model. This really began for me as one of the first areas I'll review is the program evaluation, which I see as we're systematically gathering and creating evidence here around the medical home model in the VA. Next, I'll focus on our recent efforts to develop an embedded research team within the Office of Primary Care, which really our goal here is to provide a link between data capabilities, research infrastructure, and evidence to inform national primary care policy in the VA. So in this context, embedded research really describes activities that are conducted by research teams working within healthcare delivery systems in close partnership with health system leaders. The final section of my talk will discuss work with local and national clinic leaders and how to integrate research into clinical care. So this is a broad overview of what I hope to cover today and put my work into perspective. Before I review the work, I'd like to review sort of the overall structure of the VA, which is really unique and has some attributes which allowed some of these activities to occur. So the VA is a large integrated health system providing care to over 9 million veterans in fiscal year 2020. The VA has over 350,000 employees and operates primary care clinics at 170 medical centers and over 1,000 outpatient facilities. The Office of Primary Care, who fund our analytics team, is in charge of policy and planning for primary care at the national level. The VA is federally funded. It has a cabinet level secretary. It's a capitated payment system to regional networks shown here on the map. Here we are up in our VISN. They're called VISNs, Veterans Integrated Service Networks, and we have a salaried medical staff. So there's some really unique advantages to the VA as a researcher and in program evaluation, including a dedicated research appropriation available to VA researchers. And the VA also has more than 20 years of electronic health data in a national corporate data warehouse. Over the years, there's been a development of a robust performance and quality improvement system as well. In terms of primary care within the context of the VA, I'm going to review some changes over the years that inform both clinical operations and our evaluation efforts. Before the 1990s, when I was in med school, the VA was loosely centralized collection of hospitals, and less than 10% of patients were actually assigned to primary care. The VA really restructured in the mid-90s into these regional networks where funding was provided for populations of patients and not facilities. At this point, about 80% of veterans were assigned to primary care. Again, the VA was an early adopter of a universal electronic health record, and again, used this information to develop a really robust performance and quality improvement system. From 2000 to the present, other VA initiatives included the integration of mental health into primary care, the near universal empanelment of patients into primary care, and a medical home initiative called the Patient Aligned Care Team, which rolled out in 2010. The Office of Primary Care funded a 6-site evaluation and demonstration lab initiative called the PAC DLI in 2010. This was directed by Steve Finn, who has recently stepped down as our division head. And I worked with Steve as the associate director for the national evaluation of this effort. When funding for the PAC DLI ended in 2018, we restructured and developed an embedded research team within the Office of Primary Care called PAC. This is under my direction. This is a Zoom call of our team. You can see our message to everyone here with our mission of our group to provide evidence to the Office of Primary Care for its top priorities, which include continued evidence around the medical home model, high-risk patients, and virtual care. Our team is made up of health services researchers, administrative co-lead, a program manager, several program analysts, and data scientists, statisticians, and data managers. And everyone's picture is listed here. In addition to our core team, we also have a really large group of collaborators with research scientists across the VA enterprise. Each dot on this graph represents a research investigator, and the color represents a different site of work. And the lines represent collaborative interactions in the past 5 years in terms of grants, projects, and publications. So next I'm going to shift to the work that we're doing and some of the current focus areas of my work and also with the analytics team. The first 3 areas here are really the priority areas of the Office of Primary Care. I'm going to end with work that I do at the local level, both with developing this randomized QI lab, the innovations lab, and also some local research projects. So the first area I'm going to focus on is evidence around the patient-centered medical home, which was started with the PAC Demo Lab initiative. And this really still remains one of the key focus areas of our group. This work has really influenced policy in the VA regarding continued efforts to support the medical home model through the system. So the goal of the PAC Demo Lab initiative was really to evaluate and accelerate the implementation of the medical home through the VA. And this really, the initiative was focused on developing team-based care in primary care. A lot of expansion was done on non-face-to-face access to care, including telephone clinics and secure messaging from patients to providers and teams. There was also an increased staffing ratio of nurses into primary care as part of this initiative. The goal of the initiative of the evaluation was to support the Office of Primary Care with evidence-based synthesis of data and findings. And really this effort led to the development of a group of researchers and analysts with significant expertise in the areas listed here, including the medical home implementation, the clinical quality. We did a lot of work on staff experience and burnout, team functioning, patient experience, and cost. So one of the main questions of the national implementation of PACT was how can we actually measure implementation across a large system of almost 1,000 clinics? And this was an effort I led to answer this question. Challenges to measurement included the fact that implementation started in 2010 with no control group. And the VA, as I described, had a lot of features that other systems were using to measure the medical home, including patient empanelment, an electronic health record, panel management tools, the performance and quality system, and integrated mental health care into primary care. So the goal of our measure was to try to measure the extent of the medical home implementation in the VA, utilizing existing patient, provider, and administrative data. We wanted to reflect processes and attributes that we felt were essential to primary care and describe variation across the system. I led the development of something called the Pact Implementation Progress Index, which the main components are listed here, along with the data source and the number of items for each component. So these are the domains that we felt were necessary for primary care provision, and these are the sources of data, and this is the number of items. So the first 4 domains, comprehensiveness, self-management support, patient-centered care and communication, and shared decision-making, we use data from patient surveys, and we use the Consumer Assessment of Health Plans, or CAHPS, PCMH survey. Access, continuity, and care coordination also used CAHPS, but included data from the corporate data warehouse, which is administrative data and clinical data from the VA. We fielded surveys to a national survey of PAC personnel, and we used 18 items from this annual survey to measure team-based care. And that included questions about delegation, staff and team functioning, and working to the top of your competency. So these were the measures that we used to measure implementation. And each clinic got a score. And we noted that clinics that scored in the highest quartile of implementation had significantly higher patient satisfaction, lower staff burnout, higher proportion of veterans meeting criteria on multiple quality measures, and lower emergency room use. I led a follow-up study that looked at the clinical quality by domains of the medical home model as measured by our index. In general, we found that higher scores on each of these 8 components were associated with better performance on clinical quality indicators. And we examined 48 indicators that are very similar to HEDIS measures. They measure chronic disease management, immunizations, and cancer screening. So the figure here shows a plot of the number and percentages of clinical quality indicators that were more likely to be met in clinics that's scoring in the top quartile for each of the listed domains. So on the x-axis are the domains of the implementation index, and on the y-axis are the number of clinical quality indicators. The blue bars represent the number of quality indicators that were significantly better if the clinic scored in the highest quartile for that domain. So for example, the care coordination domain, clinics in the top quartile were significantly more likely to complete 69% or 33 out of the 48 clinical quality indicators. Similar results were noted for access, continuity, and communication domains. More recent work by Linnea Shetner in her HSR&D fellowship reported on quality of life by medical home implementation. And she found that veterans served in clinics with higher implementation scores actually had higher physical quality of life, shown here. We also reported on rates of burnout in primary care and really found rates that were comparable to other systems, with almost 40% of primary care staff reporting burnout. We looked at associations with burnout and found that burnout was more likely with inadequate staffing, turnover among team members, and panel size that was over capacity. We found certain features of the medical home model that was associated with lower burnout. This was if you were on a team that had participatory decision-making and was fully staffed. In terms of the magnitude effect, here's a graph showing higher burnout on teams that were not fully staffed, had some turnover, and were over capacity. So the rate of burnout on these teams you can see is 58.6% compared to this much lower rate of 28.5% on teams that were fully staffed, had no turnover of staff, and were not over capacity. So this and other data from our team has been used by national leadership to support the continued deployment of the medical home model in the VA, and really to support staffing models for primary care teams. Next, I'm going to shift to our second area of focus for PCAT, which is the care of the high-risk patient. We're lucky in the VA to have such great work on advanced risk prediction. The VA has really been able to capitalize on its large data repository of data spanning many decades. The model here is shown is a paper called Predicting Risk of Hospitalization or Death Among Patients Receiving Primary Care in the VA, called the Care Assessment Need, or CAN score, and this was developed by Steve Finn. The score was developed using data from over 4 million veterans enrolled in primary care. Initially, it had 90 input variables from 7 domains in the administrative data. Current version has less, it's 36 variables, but has similar predictive accuracy, which is listed here. And primary care teams are able to review a report of all their patients with CAN scores, showing the probability of these events from 0, which is low, to 99, which is very high. Our group looked at where patients in the highest 10th percentile or 90th percentile and above were actually cared for in the VA, and really found that most patients who are these high-risk patients for hospitalization are cared for in general primary care clinics. and not in this subspecialty clinics like geriatrics was 2% of these high-risk patients and 3% were in home-based primary care. So I was really curious to know about what doctors, nurses thought about using the CAN score and how they used it. And this study was featured in the VA Research Bulletin under the heading, Study Gauges VA Provider Views on Predictive Analytic Tools to Assess Patient Risk. So what we did here was conduct an electronic survey on 400 CAN score users over a 3-month window in 2016. We used items from a survey called the Systems Usability Survey, in addition to having an open-ended response field. In general, we found that clinicians thought the CAN score accurately represented their patients. You can see 69% agreed or strongly agreed with that statement. And these people generally said they used the CAN score regularly, although this was a survey among users, and they felt they were able to use the score. But some did report a need for additional information. And there was about 30% of respondents who were neutral when they were asked if they were confident in their ability to use the CAN score report for clinical practice. And in the open text fields, several respondents reported the need for additional help in using these scores. I need guidance on what the intervention will make the most impact for patients. We need more data about what to do for high CAN score individuals, are 2 representative quotes. So in an effort to follow up us on this idea for how to target services to these high-risk patients, the Demo Lab and PCAT have continued to fund work to try to identify subgroups of high-risk patients to target clinical services. And this is a study that I'm showing using item response theory, which is a technique to group like individuals to develop phenotypes of high-risk patients. And this study reported on 5 high-risk subgroups as shown here. So the headers are the high-risk subgroups, and these are the diagnoses that are contained within that subgroup. And so these are not surprising to practicing general internists. The groups are substance use, liver, cancer with mental health, cancer with cardiometabolic, diabetes with cardiac, and complex mental health. So the next steps of this effort in high-risk patients is to really pilot test different care pathways for these subgroups, and this work is ongoing. So I'm going to switch next to our next priority area, which is telemedicine in primary care. I'm going to provide just a brief overview of what we're working on here, as this is an emerging topic. Because of our existing data capabilities, we were actually able to rapidly report to national leadership on the use of telehealth after the pandemic, showing really the rapid mobilization of telemedicine in the VA in primary care after the pandemic. So the orange line here represents, this is pre-pandemic, and here it is March 15th last year. And this represents the telephone visits in the VA. You can see there's a dramatic drop off in the face-to-face, which is green, and a slight increase in the video visits in the purple. Secure messaging kind of stayed the same. So we were able to rapidly provide this information to leadership for national monitoring of our system. We're also leading a 5-year program evaluation for a telemedicine regional hub program called the Clinical Resource Hub, CRH. These regional level resources will provide telemedicine services in primary care, mental health, and some specialty care to veterans in clinics without these services. This map basically shows the hubs are in blue, the blue dots, and they serve clinics going out to these spoke sites. PCAT is leading the evaluation along with our collaborative partners from around the country that are shown here. And what we're going to be looking at in terms of evaluation are cost and implementation, but also the veteran experience with telemedicine, the work experience with telemedicine, and of course, access and utilization and quality of care. We are currently in the first year of this 5-year evaluation program. Next, I'm going to shift to some Work that I'm doing locally with clinical leaders, both with PCAT and with a research study I'm conducting in conjunction with our local clinic. So one of the local projects is called the Primary Care Innovations Lab. And really the goal of this lab is to develop a partnership between our analytics team, PCAT, Health Services Research, and our VA Puget Sound General Medicine Service. This was launched in 2020. It's directed by Stephanie Deeds. The scientific lead is Ashok Reddy. Funding, program, and analytics support is provided by PCAT. Our operational partners in GMS are listed here: Anders Chen, Lauren Best, Chris Vanderwalker, and John Geyer. The idea here is to rigorously evaluate operational and QI interventions in primary care at the VA Puget Sound. This group has been successful in getting 2 projects up and running. Stephanie Deeds has done an amazing job to get the processes established with an operational committee formed here. Basically, the operation committee does project review and selection. So one of the main operational priorities in the fall of 2020 was catching up on delayed preventive care, including fit kits for colon cancer screening. So one project that's ongoing will be looking at different messaging strategies to encourage return of auto-mailed fit kits for colon rectal cancer screening. These are going to be automatically mailed to veterans, and they'll be randomized to different messaging to have them return their kits. The team rapidly pivoted to a second project in January with the launch of COVID vaccinations at our site, which was largely led by local GMS leadership. And the group designed a randomized intervention to test different messaging, text messages to encourage vaccination among veterans. The randomization of over 20,000 veterans to 3 messages began in March. And this is the consort chart showing the randomization scheme. I just want to call out the importance of the synergy between our underlying infrastructure with PCAT, with research, statistical and analytic support. There's a code being called, sorry. In conjunction with clinical leadership, which allowed the randomization of over 20,000 veterans to these different messaging strategies shown here. We were able to rapidly analyze data from these 6,000 veterans in each of the messaging types. One of the messages was a standard text message reminder to schedule the vaccine. Another message was around scarcity, and the third message was around social good. These are really recent data, and the preliminary results suggest a 25% return from all of the patients who received these messages, with really no difference amongst the control scarcity text or social good text. The really cool thing here is that we can do some rapid iterative refinement of the text-based strategies and test it again. And that's the idea of this rapid randomized QI testing lab. And this is just really exciting work, and it's been a really fun project so far. The next study that the next thing I'm gonna talk about is a study that I developed with local clinical leadership. This is a study funded by Health Services Research at the VA. And the idea here is to develop a peer support program to target high-risk primary care patients. And this program is called Vet Coach. I just want to call out that this program was really developed in conjunction with local clinical partners, including Chris Vanderwalker and Tiffany Fennell, who is a health psychologist who has been instrumental to this project in terms of training and supervision of our veteran peer health coaches. This is a 4-year randomized trial to test the effectiveness of a home-based peer health coach program among veterans with poorly controlled hypertension. And you can see the outcomes here are blood pressure and cardiovascular risk. The intervention was conceived as home-based visits with with the peer coaches, which we did until the pandemic, and then we switched to telephone visits. The coaches provide brief health education to promote behavior change. They do goal setting and action planning, and they link to appropriate community-based and clinic resources. We developed a recruitment method with the goal of recruiting a really diverse patient population from areas with high rates of hypertension. And the way we did this to identify the target areas for recruitment is all of the addresses of our patients are geocoded. And we linked those addresses to the 2010 census tract boundary file to figure out where people lived. Then we generated spatial distributions of hypertension prevalence in each census tract of our patients. And we selected 60 of those tracts with the highest prevalence of high blood pressure, and recruited patients from these selected census tracts for this program. So this is our map that we generated of hypertension prevalence of our patients from the VA in Seattle. And you can see here's just to orient everyone, that's the Seattle VA. Each of these areas is a census tract with a number in it, and the colors represent the prevalence of high blood pressure in our patient population. So basically what we did was we selected the census tracts that are not blue to recruit patients. And this strategy really led to a successful recruitment of a diverse patient population. The baseline demographics are shown here. So all of these patients had a diagnosis of high blood pressure, but you can see the prevalence of other cardiovascular risks here. Almost 20% were smokers. These were their baseline high blood pressure readings. And in terms of race, ethnicity, and income are shown in this column. The baseline the baseline percentages of white patients was 49 and 28% were Black, and 14% were multiracial. This is a low income population with almost half having an income of $40,000 or less. So this is a potentially reproducible GIS method that other health systems or other programs could adopt to target services for communities with high risk disease prevalence. And this project, I think, highlights a theme from my work, which is working with clinical partners and using data at both the national and the clinical and the local level to improve care. This study is ongoing, and we will finish intervention this year. So over the past 30 minutes or so, I've taken you on a tour of my work from pretty much the past decade, working with both national level program leaders on a program evaluation, as the director of an embedded research team, PCAT, and at the local level with our randomized QI lab and with my veteran peer health coach study. I really tried to highlight work with local and national clinical leaders on how to integrate research and clinical operations, because all of this work was done really in conjunction with clinical leaders to try to really close the loop from evidence to practice that is the ideal of the learning health system. So that's the ideal, and now I'm going to shift to some discussion about the challenges of doing this kind of work in health systems with clinical operational partners, and some ideas for how to make these relationships work. So I've listed a few challenges on this slide. This is from the research perspective. I'm sure from the operations perspective, there's other challenges, but this is from the perspective of being an embedded researcher. The first challenge for working with clinical partners is that the timelines are very different than in research. Answers are really needed in a more rapid fashion than researchers are used to. We've been doing this RCT for 5 years, for example, and that is usually not the time frame that healthcare leaders want evidence. Healthcare data is really messy, and health systems need timely solutions, and that can challenge the feasibility of implementing some more rigorous research methods. And the level of evidence required is just really different. Oftentimes we're asked to evaluate a problem, but the question isn't framed in one that could be answered. So we have to work really iteratively in defining what the scope of the problem is and how it can be addressed by evaluation, evidence, or research. I think developing the trusting relationship with clinical leaders takes a lot of time. And in our situation, the VA is a publicly funded system in a pretty polarized political environment. And there's often this pressure for fast results and multiple levels of influence in such a large national system. So these are some challenges that we encounter doing this kind of work. Given these challenges, our group and others have really thought about developing strategies for working with organizational leaders. We've been really building capacity in our group around ongoing, frequent bidirectional contact with our team and operational leaders. This is both at the national and the local level. At the national level, integration of our team into the Office of Primary Care governance structure and integration of our team into the development of primary care initiatives, both locally and nationally. For PCAT, we have a shared governance accountability between our analytics team and primary care leaders. We have a scientific advisory board that oversees how we work and attempts to ensure alignment to operational priorities. This includes senior VA leaders from research and operations, and it meets twice a year. And these types of activities were endorsed by a recent conference on embedded research, and the citation is given here. Some other strategies we have found to be successful are developing mechanisms for sharing results. We have short evidence briefs and slide decks as a way to do this. We often use qualitative research to develop narratives to triangulate some of the quantitative findings. In the face of funding uncertainties, which always is there, you really have to capitalize on opportunities to show value to the organization. This is done by providing evidence, being a knowledge broker, being willing to put in the time with leaders to understand their priorities and their need for information. And we've also in PCAT done, I think, a good job of delineating our scope of work and focused on priority areas of our funders. Primary care overlaps with a lot of different other program offices, so we have worked hard to define our strategic goals for our group. I think a lot about how to measure success in this type of health system work endeavor. We want to influence policy and guide practice with a focus on studying healthcare delivery. For example, I think the work that we've done on the medical home has helped support the ongoing team-based care efforts for the Office of Primary Care. Our group also provides value through program evaluation. And our current projects is in evaluating these telemedicine regional hubs. We also publish in peer-reviewed journals to share knowledge and enhance our organizational reputation. And I feel strongly that our success is also measured by training and advancing junior faculty and investigators. So what about any of my experience at the VA may be applicable to other systems? I think for health systems research is the fundamental critical element is organizational and leadership support in a learning health system. Embedded research teams also need the appropriate skill set. We have health services researchers, we have data scientists, we also need implementation researchers and implementation expertise. But I also think there's a lot of expertise needed in communication and administration to make these kinds of embedded teams work. There is, again, this need for bidirectional, ongoing, frequent communication between the healthcare leadership and the team. And I think this is really fundamental. Otherwise, projects are not going to be aligned if this step is not in place. And obviously, time and funding is needed for this step to occur. And I think that is the challenge in funding and in academic advancement. The non-VA federal funding for health systems research is limited as compared to like the NIH funding. So I want to make a few concluding statements, and then I'm happy to take questions. Hopefully I've described learning health system as a promising model and given you sort of the framework where I put my work into this model. And I've reviewed my research and evaluation efforts within the context. I just want to highlight a few things. I think the keys to success of working with health systems to really improve the chances that research will be relevant and actionable are, again, leadership engagement, development of trust between research and care leaders, use of methods that are both rigorous and rapid to provide results, but also for longer term research studies, integrating clinical leaders into research to make sure that our research addresses the priorities of healthcare leaders and the patients that they serve. So I'm going to stop there, and I'm happy to take any questions, and I've given my contact information at the bottom.
Thank you so much, Dr. Nelson. That was really awesome.
Thanks, Johnny.
And highlighted a lot of the unique aspects of being at the VA that allow you to work in this sort of unique implementation model of the integrated research team. Welcome to ask any questions in the chat for the audience. One question that came up, can you talk about ways that you have found were helpful to build trust across disciplines?
I think trust is just a critical feature of most relationships of humans. So I think it's building relationships builds trust. And that's, done in a lot of different ways. I feel like what I have done over the last 3 years or how long it's been with PCAT is spent the time to actually get to know people personally. And I think that we are really blessed with an extremely skilled executive director in the Office of Primary Care who realizes the importance of the relationships in her team and has done a lot of work in that area. So time and really being honest and getting to know people is what we have done.
That makes sense. Some comments about just thank you, and that was a really wonderful presentation. Seeing the question here about any preliminary results so far from the health coach study.
I wish. It's my labor of love over here, and we are ending the intervention. We have some really great qualitative data from people who've gone through the program, from veterans who highly endorse having another veteran help them with their health goals. And so we've gotten a lot of really great positive feedback for the qualitative surveys. There is definitely a bond that veterans have, having been in the military. And I think that we are capitalizing on that and really helping people support other veterans. So this is the qualitative. We will have more of the quantitative within the next year, I'm hoping.
Awesome.
Thanks for your interest.
I think a really thoughtful question here. How do you lead the team through like a big idea that didn't work out? So I was struck by such a great idea to think about how text messaging might influence, vaccine returns, and then seeing that didn't work out. How do you sort of push through that and continue to sort of keep morale up?
Oh, that's such a great idea. This team of the Innovations Lab over here is truly amazing. I am so excited about this work that we're all doing together. And we did have this conversation about like all these negative studies that we do. And sort of the next step is being iterative and saying, okay, so that didn't work. What can we do next? And I think that's the beauty of having this rapid cycle, because you don't get stuck in I just did the study for 5 years and it was negative, because I've definitely had that. And that's a little bit more depressing than, okay, we did this for 3 months and it didn't work. There's been other systems who have done this sort of rapid cycle QI RCTs. And I was just reviewing one of the papers from NYU, and probably only 2 of their projects were positive. So, you're showing a lot of things that don't really make a difference, which might be of value to a health system if you're spending a lot of money doing something that doesn't make a difference.
So focusing on throughput as a way of getting to the good answers and not focusing on each individual instance.
I think so. Thank you
Yeah.
for summarizing that so well.
Well, it's reminiscent of the
Yeah.
A/B testing that Google or some of these companies do, right? So
Right, and that's the idea with
a
innovation,
learning
right?
model, right?
Right.
A question in the chat came in regarding peer coaching and hypertension and diabetes,
Mhm.
with a significant proportion of those patients being veterans of color. Can you discuss some strategies you're using to mitigate disparities in those populations?
Well, I mean, I think our recruitment strategy was one attempt to mitigate disparities by focusing on populations of patients at higher risk, which by definition tend to be minority patients. So that was my goal of the GIS mapping, was to actually find areas of our region that have higher disease prevalence. We also recruited our coaches from those areas. So we have, over the course of the study, have recruited about 6 coaches, and 4 of them were Black. So we also tried to do paired concordance around where people lived and if they were able to manage their chronic disease.
Yeah. Another question here, sort of related to the null findings. How, when in sort of discussing those findings with your operational partners, do you recommend framing that outcome?
Such a good question. Yeah, I mean, I think that, again, it gets back to the relationship you have with people. If you can actually be really honest and say, okay, this was a negative study, or this didn't show what we thought it was going to show. If you have a relationship with that person, it's much easier to talk about studies. And we've done that before, where we did a study where we looked at, did the change of the implementation index show any difference in hospitalizations and ED visits? And Ashok led this study. It was in JAMA Network Open, and it didn't show any difference. And we presented to our partners and said, we didn't see anything. And one of the main clinical leads was like, oh, okay, well, that's good to know. I mean, it wasn't like it was, there's just a really open, honest conversation about it. So I think it's more, if you have the communication already set up, it's built into your communication stream about what you're working on and what the results are.
You don't have to work so hard to frame if you have the foundational trust that you were
Yeah,
talking about.
yeah. I mean, if you talk to somebody every month, it's not like you're going to have to, sort of reframe what your work is.
A couple questions here, both focused on sort of highlighting how you value integration of junior faculty into this operation. And one question specifically, can you speak to how you've pulled junior faculty into your operations work? And then the second part of this question might be, and what advice do you offer to them, sort of so that they can be as successful, so we can be as successful as you've been in your career?
Yes, that's such a good question. I think we are so blessed at the University of Washington with extremely talented junior faculty. So I feel like everybody that I work with is really just they have so much skill already. And I just try to really mentor them in terms of figuring out what they want to do, what their goals are. And that's how I get people to work in our group, is like, what is your, Stephanie and I talked about the innovations lab. What does she want to do? What was her vision for it? And she really took off and did all the operations part of it. And having people that just want to work on these areas is how I find people. I don't really have any like set criteria. It's more if people have a passion for it and are really interested in working in that area. And then there was a second part of the question that I'm forgetting.
What advice do you offer to folks to sustain that level of productivity throughout their career?
I think mentorship is key. You need to find people that you want to be. You want to talk to them and help and have them be your mentor. I have been blessed with extremely good mentorship over the years, and I'm trying to do that to put that out there for my mentees as well. But I think when I see people who don't do well with that, is they don't follow up. They maybe talk to you and then you don't ever hear from them again. And it's kind of like, oh, okay, well, that's fine. Like, I don't need to talk to everybody all the time. I don't need to mentor everyone who comes to see me, but having some kind of system for junior faculty where when they're approaching people, to have an idea about what they want to work on, what they're passionate about, what they really want to work with, how they want to work with you is really, really important. I don't assign people projects. I I have tons of stuff that I could tell people they should do, but I really want people to want to work on it.
Awesome. Thank you for that. That was a great answer. A couple questions coming in, one sort of on a similar theme, but I want to pause on that and switch over. There's a question here about how your group might be integrating or attempting to assist other sort of federal beneficiaries, in particular the military health systems leaders. Is there anything in place to sort of help them deliver care to their 10 million beneficiaries?
Ooh, that's a good question. So the VA system and the DoD's medical systems are pretty separate. There is some, you know, integration, like we're getting the same medical record as the DoD. That was part of one of the ideas behind that. But yeah, we really, I have to say, I haven't really integrated a lot with the Defense Health System. We've interacted with them a little bit around the medical home because they also rolled out the medical home, but they have very different patient population. They're dealing with keeping people service ready, and we're dealing with older veterans with chronic diseases. So it's a really different model of care.
Yeah, that makes sense. Yeah, in an appreciation in the question of how many potential obstacles there are to sort of that, to bridging that gap between those two big branches. Maybe the final question here, how do you recommend that residents progress towards a goal of impacting healthcare delivery at the community level as opposed to hospital or clinic-based level?
Yeah, I mean, you have to pick where you want to work, really, right? If you're, I mean, I have straddled sort of the community-based interventions from a health system. That's what I've been working in. And I worked with the health department on a study. I've moved it to the VA where we're trying to do more community-based interventions from the health system level. Or you can just say, you know what, I'm going to be like Jim Krieger, who is in our faculty, who went and worked at the health department. And they really, their focus was on community-based interventions from the health department level. So you can do either. I mean, and you should become a generalist because that's what we do. So come and talk to me about that. But you just have to decide. I think there is some value for health systems to do community-based work. I really believe that. Some people at the VA don't believe that. They think we should do healthcare. So it's really sort of defining like what that means. You know, population health in my mind infers that you're going to do some community-based population health. You're going to care for a population of patients, which in definition is sort of public health. So that's kind of, you have to just figure out where you're going to put your mark.
Where you're going to make your mark. Well, thank you so much. A really marvelous presentation, to quote a comment in the chat. And thank you for your hard work, your clear passion about this subject, and for mentoring and pulling so many junior faculty into this work. We really appreciate it.
Thanks, Johnny.
Yeah, of course. Thanks, everyone, and have a great rest of your Friday afternoon.
Thank you.